Hello, hello. Good morning, good afternoon. No, I'm here in Brazil. It's 5 o'clock in the afternoon. It's really a pleasure to be together with the American Academy of Oral Surgery. So I really, it's really a fantastic opportunity to discuss immediate implant placement in the static zone. That's a topic that we've been working for some time, and well, let's see how we can evolve in this situation. So the first thing to understand is that okay, this is a Groisman et al. Work. I didn't do everything myself. I had a fantastic group. I had the pleasure to work with different dentists, with different groups, and the people in the office. They are just fantastic. And I also had a chance to be impacted by different colleagues and teachers, and I think I own them. And thank you very much for this. It's a great opportunity to be here with the American Academy of Oral Surgery, and also to present the work that I did with these fantastic people. So what's very interesting to me is that in '84 we start working with implant dentistry in patients who were already using full dentures. And now we are working with patients in different age structure, with different biological structure, and we have to recreate teeth that were not the main goal of the technique when we started. When we started with implant dentistry, the question was to have anchorage, to have a possibility to have a full denture that was stable in the patient's mouth. And today we are working with single teeth in the anterior region. Well, we've been following a lot of different guidelines, and well, in the 80s and 90s, we were searching for shortening the time of the treatment, and one way was to get a bioactive implant surface. So in our clinic, we start working with different surfaces. We had the opportunity on those times to work with plasma spray of titanium and pure titanium and HA coated implants. So this is a clinical study that we evaluate HA coated implants in single tooth. And this was a retrospective study of 5 years. And what was very interesting, this study, the finding to me was very interesting, that 33% of the implants that we were placing in my clinic were single implants in the anterior region. So we had to really to be aware of what was going on in the study. So let's have a look at this case that we placed the implant in '97. We extract the lateral incisor that was with internal resorption, and we immediately placed the implant. And here we have the case in '98, 1 year after we placed the implant. It's a very good result for the time being, no? And here I have the possibility to follow this case for 2 years, for 9 years, for 15 years, 18 years, 20 years. And we see that we had a pleasant result, and well, very little changes were observed around this implant. So if this happens in '97, well, I have to have the chance to replicate this situation. So let's see the case now in 2019, so 21 years after implant placement. And here I have the case is 22 years, and now the case is 23 years. So it's we lose a lot in terms of buccal contour volume, but anyway, the case is very interesting. There is no need to change, and the patient's very happy with the result of 23-year implant placement. But on the other hand, in the same studies, we could see that there were cases like this, and that they were considering integration, but this is not the result that we wish to our patients. So if we look at this and we look what happened to these patients, that from those times, these implants, they were very nice, adapted to any success criteria that were used in the literature. For instance, on those times, we were using the criteria of Albrechtsen and co-authors that were published in '86, and these implants they were doing fine. Okay, aesthetically we have a problem, you know, but the parameters did not uh, approach aesthetic as a factor of success or insuccess in relation to implant placement. So what happens that also to shorten the working time, we start not only work with the implants in the phase that we call late installation, that we use to extract the tooth, wait 6 months to place the implants, and then wait 6 more months to do the second step surgery. And normally with 15 months, we had the restoration settled if everything was okay during all the phases of treatment. So we start working with early installation, and this is a technique that we didn't like very much, but it's you do the extraction and you place the implant 2 months after you do the extraction. The question was to have soft tissue to allow us to do a bare bone regeneration procedure. No, and the third aspect, that's the immediate installation, that's the topic of today, and that we use to do the extraction and place the implant immediately. And today, what we are doing, we are doing the extraction, we place the implant, and we come with the prosthodontic component, and then we go to the provisional at the same time as the implant installation. So let's have a look. What also appeared to us is that different from the past, we need to understand a little bit of the tooth volume, of the tissue volume that we need in order to have a reconstruction in a nice way, if it's one single or another, or double or two or three implants in the anterior region. But then we understood that for peri-implantar aesthetics, we need to change the volume of the things. So as a matter of fact, what we see here, is that we consider that they have a problem, and this problem starts when the patient arrives in the clinic losing a tooth. And this is the main problem, because after he loses a tooth, we have a sequence of events that makes it that there is a change in the anatomic situation of this alveolum, and then we lose volume. And aesthetically, it's this is very important, because mainly if you want to think about osseointegration, probably there is enough bone to place the implant. The question is to have the implant in the right position, and also to have the chance to have the tissues around the implant that are going to allow us to have a mimetic restoration. So these are different scenarios, and as a matter of fact, we as clinicians, we try to simplify and we try to look for classifications that will allow us to go in one direction or the other direction when we see the signs and symptoms of a tooth who is being loosed. But exactly what happened here is that in all four cases, we go for different treatment options, but the goal is the same, is to allow the patient with a symmetric and aesthetic situation with a good clinical result. But for this, we need to answer some questions. First, when am I going to place my implant? Second, how am I going to place this implant? And third, why am I going to place this implant? For this, we need guidelines. All the time we need guidelines. So let me show you one guy and one paper that impact my life in the clinic very much, And this is the paper for Peter Worley. Peter Worley lives in Newport Beach, California, and this paper was published in '98. And he talks about single tooth replacement in the static zone with immediate professionalization, and he did it in 14 consecutive cases. And these photos in the centers are original photos from Peter Worley, and we see that to place the implant, we need to have a bone all around the tooth that we are going to extract. Very interesting, this technique is that Peter Worley did not recommend us to open flaps. And this was the first time with osseointegration implants doing immediate extraction that someone comment about not open a flap. And this goes straight to the fact that we want to have vitality, that want to keep the vascularity, and this is going to help us with the volume. The other issue concerning this study is that, okay, the intention was to put an implant that could take really the space of the alveolus, and also to go into the direction of the tooth that was extracted. And this we don't do any longer, but this was how we used to do it in the past. So with this technique, we start doing some cases in our clinic, and here I present you some of our implants that what were done immediately, and here you have some X-rays. And since we start having volume of work in this type of technique, we decided to do a study, and we did a 2 years perspective study. We wanted to know in reality, how was this technique in terms of success, not only for us, but the perspective of the patient. And here you have the cases 2 years after we placed the prosthesis. And what was interesting about this study is that in reality, 42% of the implants that we placed, if you see in the table, were implants with large diameter, so 5 and 6 millimeter diameter. So this doesn't mean that the results were bad. No, but of course, if you follow the patient for 2 years, and in my situation, as I still have my practice for 30 years in the same address, the patients, they are always coming back, always. Even if cannot have a fantastic program of maintenance, no, the patient that does implants, he always come back. And so here I have my patients 12 and 14 years after this. What I want you to pay attention when I show these pictures is that sometimes a 2 year time study is not enough to analyze the long-term result of our treatment. And if I try to identify the causes of these aesthetic problems, I would drive myself to implant position. Now, I think implant position is a very key and important issue. So exactly to try to understand and to try to measure what was going on aesthetically, we understand that, okay, we have to go to the periimplantar parameters, and we see the patient and we expect the patient to have symmetry and harmony. But for this, we are going to divide the periimplant tissues in buccal contour and papilla. So let's start talking about papilla, because this was how we started in our lives also. The first paper that I want to refer when I talk about papilla is the paper from Professor Tarnow and co-authors in 92. In these papers, they showed that the distance from the contact point to the bone crest, if it was until 5 millimeters, we will have papilla filling the space. If this was more than 5 millimeters, 6 and 7 millimeters, the percentage of papilla fill was decreased very much. The same number, 5, was also observed by Schuckert and co-authors in 2001 when analyzed a tooth to implant space. And one paper that's very interesting that concerns papilla in implants is this paper from Torsten Jemt that was published in 97. And this paper is very interesting because he created an index to measure the papilla, and then in 25 implants, he measured the papilla when he placed the crowns, and 1 year and a half later, he invited the patients again, and he measured the papilla again. And he showed that the papilla grows with time. And this was very interesting to see, because, the question that we were thinking about was just to have an opportunity to do surgery and increase the papilla volume. But most of the time, there was no need, because this was a biological constant, a biological number. So if you look here in this case that we did in 2007, now the first picture in our left aspect, you see the implant with the provisional. And then in the center aspect also, just the questions 3 months after we placed the provisional. And the picture of 2008, it's already with the definitive crown that was placed by Dr. Silvana Spirides from Federal University of Rio de Janeiro. And here I have the case with 8 years, with 10 years, with 11 years, with 12 years. No, we see that very, very little is changed, but things moved, and this is not a statical situation. It's a very dynamical situation, and we have to be prepared. For instance, when I look at this patient 13 years after replacing implant, I see that the incisor border of the implant is shorter than the incisor border of the contralateral tooth. And the other issue that's very interesting that we always observe is the shortened papilla time that we have in the distal aspect. And this was the first time now in this year, that we have a group of friends from Spain that they approach this aspect. So you see that we are in an improvement moment. We are all the time changing aspects and understanding the results of things that we couldn't do before. But when we think about this value of 5 that was observed by Professor Tarnow and by Schocket, the distance from the contact point to the bone crest, we see a very interesting paper, from Hokuzo with a systematic review, and he could not conclude anything in relation to this figure. And what he showed us very much is that the measurements that we are doing, they are not patronized. So what happens that someone measure from the contact point to the bone using the tooth, the other using the implant, and the distance are very different. But he showed that there are a lot of factors that are involved with papilla, and these are things that we have also to pay attention. It's not just one factor that's going to affect papilla, it's a multifactorial aspect, and we have to keep this in mind. So the other issue is the buccal contour, because we have changes, horizontal changes that we lose volume, and we have the changes in position that normally we have recession. And when I see recession, I normally related it to the implant position. And also in the literature, for instance, Cozin, together with Hugo de Bruyn, did a very nice study. And in this paper, what we can see that they published in 2012, that the buccal contour was affected very much by the position of the implant. And this we cannot deny. So in our clinic nowadays, when we are planning to place an implant, when the patient is losing a tooth, what we are going to do, we are going to think about the implant position and stability. We are going to think about tissue preservation and reconstruction. And we are going to think about the prosthodontic guidelines. So these are the three main aspects that were given to us by the group of implant perio. And one thing that's very important is that together with these 3 points, we need a fourth leg. And this fourth leg called a program of having our patients back every 3rd month in the first year, and later on that we can adapt the patient due to the risk of dental disease. One point that's very important, and I always like to talk about this very much, is the implant position. And we followed the paper, a classical paper from Sadun and co-authors that was published in 1999 at PPAD. And he indicates to us that mesodistally, the implant has to be 2 millimeters from the tooth. Apicocoronally, the implant should be 3 millimeters from the border of the crown. And buccolingually, the implant should be uh, 2 millimeters of distance from the line that touches the central and the canine, if it's a lateral incisor that we are placing, or if it connects the central to the lateral, if it's another central that we are going to place. And today we adapted this to the fact that our implants are a little bit different. So we use implants with conical connections. So we need more space to come to the right, right crown sides. So we, instead of having 3 millimeters apicocoronally, we place our implant 4 millimeter. And the other issue is that since we are using implants with platform shifting, instead of needing 2 millimeters, we can use 1.5 millimeters. These figures are very important nowadays, especially because our planning is mainly done in computer programs. So we can feed the programs with these figures, and these figures can be the basis to select the right implant position. So and now we are in the clinic and the patients are arriving, and we have a chance to receive patients that are without their own teeth, and patients that come with a tooth that is indicated to extraction. So these are the two scenarios that we have. So the first one is the healed scenario, And then we are working the classical way. We're going to open the flap, and probably we need to reconstruct this structure with bone regeneration and so on. And the other issue is to work with the patient that comes in the alveolar scenario. We have to do distraction. And if I do distraction, I can have spontaneous healing that I don't like very much. This is not a procedure that we do in our clinic. We may have alveolar preservation, or we go to immediate implant. Normally, I think that for the, the best of the patient, normally immediate implant is what the patient wants, because they don't want to go to 3, 4, 5, 6 surgeries to have the result that they could have in one single step. But so let's have a look at this. The first issue that we need to answer is, how does biology respond when they do a tooth extraction? And as a clinician, I need to understand this in two ways. One is the histological way, how it's going to heal and time of healing. And the second is the clinical view, because this is going to affect the result of my work. So if you go to the histological view, there are very nice papers from the literature. First, there's this paper from 1929, and he did biopsies in dogs. And then there are these other two papers that are brought to, also papers from the past. Now, this paper from Amler from the 60 and 69, it's a fantastic paper. They did a lot of biopsies, human biopsies, and they show how the alveolus was healing after a tooth extraction. And so they put it a time-related situation, and we can see and we can try to combine this with our needs when we are extracting a tooth and placing the implants. The other situation is the clinical view. And to show you the clinical view, I brought very nice papers also from the 1967. In this paper, Jaime Pretkovsky and Massler, they did a study with 149 patients. They extract teeth and they did impressions of 149 patients. And they showed to us that the buccal surface, you have a loss of around 3 millimeters, especially in the maxillary teeth. So these 3 millimeters are going to affect the result of the light reflection when you have, for instance, an implant in this region. Now we have the second and the third generation of papers approaching the same aspects. And what's very interesting is that most of them, they go to a reduction of 50% of the volume. But for instance, there are reductions that are very funny. And you see difference from 29% to 63% of reduction. So the spread is too big to treat this as a mean. Because when the patient arrives in the office, we need to have some parameters that are going to allow us to organize the patient and see if this patient can go to immediate implant placement or not. So to talk about these risk factors, I brought just four, and the first one is the residual bone anatomy. The second is the gingival margin. And these are factors that they are gonna be very interesting to allow us to understand when we are gonna place the implants. Because I need to have the implant in the right position, and so these four pictures at your left is a classification from Joseph Camp, from Loma Linda University, and they show the relationship of the root position and the bone. And these are things that we have to consider. The second issue is the gingival margin, because if we have gingival margin more coronal or at the same level as the contralateral tooth, normally we do the immediate implant in a nice way. But if there are very big retractions, we have to reevaluate our situation. And the other issue is not only when, but how we are going to place our implants. And this is dependent on the bone defect that we have at the buccal aspects and also the periodontal phenotype. And so these are the four aspects that are very good to understand. So if you think about the residual bone anatomy, we see this very nice classification that was done by the Loma Linda group. And they showed to us that in central incisor, for instance, 86% of our cases is class 1. This means that normally we have bone at the palatal aspects, and this is going to allow us to place the implant and stabilize it. But unfortunately, in our daily situation, this is what we see in our right side. It's patients that come with infections, patient that comes with bone resorption. So we have to pay attention because this is not really what we consider in a very clean situation. This is our daily situation. And to approach this, we have to understand that the first thing is to see if we have residual bone to stabilize the implant in a nice position. If we cannot stabilize the implant in the correct position, we have to do a velar reconstruction and maintenance. And this we can do with biomaterials, with soft tissues. There are different ways that we can approach this. And the other situations that when we can stabilize the implant in the correct position, we go for the immediate implant and we use grafts in the vestibular aspect, and we are going to use also soft tissue graft to help to compensate for the fact. So we use a very simplified classification that was presented by Allen and co-authors in 2007, and he classified in type 1 when you have bone and soft tissue. Type 2, you don't have bone, but you have soft tissue in a nice way. And type 3, you don't have not even bone and soft tissue. So the immediate implant technique was previously prepared for type 1. So let's have a look at this case. We go for type 1. We probe, we check the tomography, there is bone in the buccal aspect, there is enough bone in the palatal aspect, and we go for the procedure. We do extraction, we do the measurements, and we see that, okay, unfortunately, there is no bone. So this does not contraindicate the technique. We place the implant in the right position, as you can see in our left side, and then we do the tissue reconstruction with sionogenic bone substitutes, and also the soft tissue graft from the palatal. Here we have the prosthetic part being prepared, following the paper by Sue, and this was done in a very beautiful way by Victor Clavijo, and here we have the prosthodontic component being installed. And we have the case, and we follow the case for 1 year. It's a very short time, this is a lady of 86 years of age, and she's very happy with her aesthetics, and she's very happy with the result. Unfortunately, she lost the central. It's the first implant that she has. This is a technique that we can do it in a very simple way and reproduce it. And here we see another case that was done together with Victor Clavijo. Victor is an outstanding teacher, a fantastic personality. It's a guy that should speak in anywhere. Anyway, and we did it together with Bocabella, and here we have the result. And also, you see the follow-up from 2013 to 2016. The aspect is stability of soft tissue and the implant. And here the patient in 2019, 6 years post-op, the results very going fine. So now we go to type 2, especially type 2. And for type 2, I want to share with you this lady that is losing the central incisor. This surgery was done in 2009. And here we have probing, we always probe, as a periodontist. We do extraction in a non-invasive way. We see the resorption of the root, and this was given recurrent abscess in this situation. And then we check the situation, and we see that there is no bone in the buccal aspect of the situation. So we know it's a class 2 of Allen and co-authors, and we go for the implant installation. We always use guide surgery. We are even more, because one of the main problems that we have is really implant position. So we guided the surgery. We check it with our probe, and then we took the impression. We put the graft. We put the soft tissue graft, and we come with the component. And here we have the provisional. And this is how the patient leaves the office. 1 week after, you see that there is a necrosis of the soft tissue. Maybe the flap that we did could be done in a different way. In this time, I used to do split flap, and here probably it was a case to do a full flap. And here we have the result in 2010, how the patient is with her definitive crown. So we have her in 2011, 2012, 13, 14, 16, 17, 18. And in 2019, she started complaining about the fact that the other central incisor was too yellowish. So we did then a whitening technique, and this is the result. She's very happy with the result, and we didn't need to change anything. This is how the case is up to now. So this is 11 years follow-up, how it's maintained. The other issue is that we be impacted by a lot of new techniques, and the digital technology is going to affect us very much. And this is especially very positive. So the first thing that we have, the digital aspect, is the fact that we can diagnose much better. And then that you can reproduce the facts, and we can see the patient many times, before seeing the patient as such. And this is a fantastic aspect. The other issue is that we can measure things with the digital programs. And this is going to allow us to plan things in a different way. No? And so if we have the clinical and the biological aspects, using digital planning, we can decide which procedure, which sequence of time, and which moment in time we are going to do our implant. And this is going to allow us also to have a better communication with our team, because then this movie goes everywhere. And then we can have a better communication with the technique, with the technician, and then we can go to the surgery in a very nice way, with a feeling that I have been doing this surgery 10, 12 times in my computer. So distraction is performed in a very gentle way, and we would like to prove, and the fact that we know that 87% of the sites in the central incisor has less than 1 millimeter of buccal bone. This does not affect our technique any longer, because we don't stop our implant in the buccal bone. No, this is not the place to play. This is not the right position to place the implant. So we use guide implant placement, and we are using surgical guide from Derg. And here you have the burr. This burr has a special feature which allow us to have more irrigation in the upper part of the burr. And then we are placing our implant. So the problem with the position of the implant, we solved most of the time using guided. And here we have the stability of the implant using the guide position. And here we have the team working, Professor Rafael Monte Alto, Monique Cristiano Soares. They are using the concept of shoe, and in the meanwhile, while they are preparing the provisional prosthesis, we are using the bone graft. And here I'm using extra graft. That's a product. It's made of bone substitutes and collagen. And here I'm placing a soft tissue that was harvested from the palatal by the one incision technique. And this is inserted using the sutures to help us to position the soft tissue in the right position. 3 months after this, we are going to take the impression of the soft tissue position. We don't do it with our scanner. We do it using resin. We like it very much. And here you have Ricardo Malisi that's going to finish the case. Ricardo is working in Dubai right now. And so the cases was cemented by Professor Rafael Monte Alto and by Monique Solon. And here we have a occlusal view of the case, a lateral view, another view. And this is how technology can be adapted to the fact that we need to use the biological aspects. So this is a follow-up, not just now, the beginning of the year. So and to finish this presentation, I want to share with you this case. It's a trauma case. The patient has the central incisor in different position, and this has to be adjusted. This has to be planned. and the indications to distraction of number 12 and also number 21. These are the two ones that have to be extracted for fracture after trauma. And here we see the tomography of the patient, and we see that it's not going to be easy to place the implant in the right position here. We have pathological situations and we don't have bone to support the implant in the right position. So before doing the extraction, we are going to use orthodontic to have it lined up and to have in this situation that we need. Let's not forget the studies previously presented that, okay, if extracted tooth, the bone is going to remodel. And to compensate for this, Eduardo Groisman, my son, is doing a technique that was previously published by Kobe Landsberg and Itsam Bichacho in 94. Now, very nice use technique. And then we follow the patient and we wait after we do the alveolar preservation, we wait normally 4 to 6 months. The literature shows that there is no histological difference when you do this procedure between 3 and 6 months. So there is not a big deal. So, and we do the grafting, we wait for 4 months, and then we are doing the planning because now we need to place the implants. So here we have the planning, and after the planning, we are going to get the guide. And this guide is going to allow us to place the implant in the right position. Also, at the same moment, what we can do is we can prepare the provisionals. So we have the help of Professor Vinicius Brigagão, who's helping us to produce this material. So we go to the surgery, and let's remember, we don't want to open a flap. Since 72, we see in the literature that's better for the patient not to open a flap. And this study that I'm showing to you in 72 that has Wood as first author, they compare different techniques to treat periodontal disease. And they show that if you don't open a flap, you preserve the bone in a better way. Look, we are talking about 1972. Let's keep this knowledge in mind. And here we have the case, we know we are going to lose a little volume, and then we extract the lateral incisor, and then we have the guide to place our implants. We place the implant, we go for bone graft at the buccal aspect of the implant placement, and also we are going to use soft tissue graft. This is a way that we have to compensate what biologically normally happens when we extract a tooth. Here we see the sutures done by Eduardo. This is Eduardo at your left side. And then after the sutures, we have Ulisses Dayubi working with the prosthetic part and trying to follow the critical and subcritical aspects that were beautifully presented by Sue and co-authors. And here you have the case, how it's presented. Well, unfortunately, it's in Portuguese. There is a magazine, and we publish similar cases with the same technique. So we follow preparing the case, and now we go for a new provisional. And this, we use the fantastic help of Victor Clavijo. Fantastic guy, outstanding material. He's working with perimplantar manipulation, and the manipulation is doing very well. It's outstanding. Look the result. And now we wait 3 months for tissue maturation. And this is normally what we are doing at our daily clinic, at our space, receiving our patients and treating patients for 35 years with implant dentistry. To resume this, I would like to tell you that thinking about immediate implant placement, we divided in 3 aspects. Implant positioning, stabilization, use the parameters that were offered to us by Sadun and co-authors in 99. We are going to work with tissue preservation and reconstruction. Remember the studies from 67 from Pretzakovsky that we are going to lose tissue so we can compensate this with bone grafts and soft tissue, or who knows, a substitute of soft tissues. And the third issue is prosthetically driven situation. When we start implant dentistry, prosthetic situation, we use to place the implants, and 6 months after, we present the patient to the prosthodontist. Or a mistake. It's a teamwork. It's a work that we can do together. And we think that in the same way, we have to preserve our patients. And I'd like to thank the American Academy of Oral Surgery for the fantastic invitation. And myself, as the president of the Brazilian Academy of Dentistry, I would like to very much, share our friends of the American Academy, and I hope we can build relations for the future. Thank you very much for your attention. It's a big pleasure to be here.